Welcome to the Medical Coding with Legacy Education YouTube channel. I am Tiffany Roach, the coding coach, and this video will cover the compliance and regulatory section of the AAPC CPC exam. The CPT code set is copyrighted by the AMA. Any mention of CPT codes are not the property of Legacy Education. Healthcare is a multifaceted industry which employs all types of professions and is bound by a multitude of statutes and regulations. To help you understand how a coder fits into the healthcare industry, we will discuss coding as a profession and how that coder fits into the physician's office, as well as the differences of services provided by hospitals and those that are provided by physicians. Although some coders will not be involved in billing, it is important to understand some billing aspects in order to perform their job more effectively. To help, we will discuss the different types of payers for Medicare services, the RBRVS system for fees, medical necessity, and the ABN as it relates to physician services. It is also important to discuss the varying regulations affecting us as coders. This includes privacy and security, compliance rules and audits, and then using tools such as the OIG work plan to identify possible areas of concern. And then we will wrap up by talking a little bit about AAPC and what it means to be a member of AAPC. The coding profession has evolved significantly over the past several decades into a career path with unlimited possibilities. Many professionals who have learned coding have also gone on to roles as consultants, educators, and medical auditors. There are endless possibilities in this ever changing field. Every time a patient receives health care, a record is maintained of the observations, medical or surgical interventions, and treatment outcomes. This record includes information that the patient provides concerning his or her symptoms and their medical history, the results of those examinations, reports of any x rays and lab tests, diagnoses, and treatment plans. Medical records and health information technicians will organize and evaluate these records for completeness and accuracy. Coding is the process of translating this written or dictated medical record into a series of numeric or alphanumeric codes. Coders will regularly communicate with physicians and other healthcare professionals in order to clarify diagnoses or to obtain additional information. Coders often use computer programs to tabulate and analyze data to improve the patient care, better control costs, provide documentation for use in legal actions, and it can even be used in research studies. Technicians who specialize in coding are called medical coders or coding specialists. Medical coders assign a code to each diagnosis and procedure by using a classification system. Coders may use several reimbursement systems, such as those required for ambulatory settings, physicians' offices, or long-term care. Most coders will specialize in coding patients' medical information for insurance purposes. Physician-based coders will review charts, assign CPT, HIPAA, and ICD-10-CM codes for insurance billing, and this is tied directly to physician reimbursements, and careful thought to assigning the correct codes is essential for physician livelihood. Technicians who specialize in coding for hospitals are called health information coders, medical record coders, coders and abstractors, or coding specialists. These technicians will assign a code to each diagnosis and procedure, relying on their knowledge of a disease process. Coders will use classification systems to assign the patient to several hundred Medicare severity diagnosis related groups, or MSDRGs. And those MSDRGs will determine the amount for the hospital that will be reimbursed if the patient is covered by Medicare or other insurance programs that use the MSDRG system. Risk adjustment coding will focus on diagnosis coding using the ICD-10-CM code set. Risk adjustment codes are pulled from claims data and medical record documentation within all settings. Risk adjustment coders can work for health plans, providers, or other healthcare entities. The coding profession is unique, and once it is mastered, continuing education is ongoing. Code updates and policies are changed as often as quarterly, and it remains important to stay abreast of these changes to ensure proper coding and payment. As technology advances, the role of a coder will continue to broaden and the job responsibilities will alter. For example, as EHRs were implemented, coders were required to become familiar with that EHR software, maintaining the EHR software security, and analyzing electronic data to improve healthcare information. Coders often took on the role on the EHR implementation team for a more successful outcome. As technology moves into artificial intelligence, the role of the coder will once again broaden, and it will require a coder to adapt a new role of quality control or auditing. Coders may also find themselves on a team to evaluate and implement that AI technology. It is beneficial for coders to understand how AI is being used today. In addition to mastering anatomy and terminology, your coders must be very detail oriented. Simple words such as if and or can completely change a code selection. So special attention to the many guidelines when learning the codes is absolutely necessary. When you visit a physician within the office, you typically get one bill from the physician. Although you may get a second bill from another physician, such as a radiologist. However, when you visit the hospital, you will typically get a bill from the facility and then one from each of the physicians that are involved within your care. Codes for physician services will report the work and the overhead of the physician, regardless of where the work is performed. A physician can provide inpatient or outpatient services, and they can provide those services in a clinic, ambulatory surgical center, hospital, or really anywhere the provider can travel. The physician's services are reported using CPT, HIPAA, and ICD-10-CM, and they are typically billed on a CMS 1500 form. Codes for hospital services will report the technical component of services that are provided in the hospital facility or in a building that is owned by the hospital. These services are to cover the cost of the hospital itself and the overhead of the equipment, the technicians, nurses, and any other supplies that are provided by that hospital. Hospital services are reported using ICD-10-CM as well as ICD-10-PCS, and they are grouped into a payment classification system such as MSDRGs and APCs. Hospitals will typically bill on a UB04 claim. As with most processes within the 21st century, technology can be used to increase efficiency and allow rapid access to vast amounts of information and data. The process of medical coding is no exception. The skilled medical coder must be able to understand the basic functionality of the medical coding software and its place in the real world of medical coding. There are a number of medical coding software tools available for use in the medical coding industry. Most coding softwares will allow you to search for a code, understand those procedures in lay terms, check NCCI edits, and locate medical policies like your LCD policy that we're going to talk about later. A benefit of medical coding software is that it is constantly and consistently updated with the latest information, codes, and content. Some programs may offer add-on subscriptions for CPT Assistant or the AHA Coding Clinic. Some examples of electronic coding tools available will include Codify by AAPC, TurboCoder, and Encoder Pro, just to name a few. Medical coding software may be used as a standalone tool, or it can be integrated into practice management, billing, and electronic health record systems. Now, your physician services will be provided by a variety of medical providers. Each provider has differing levels of education. Physicians undergo 4 years of college and 4 years of medical school, plus 3 to 5 years of residency. Residency is training in a specialty of practice. A physician can continue to train in a subspecialty, and that is referred to as a fellowship. Physicians often have mid-level providers that work within the same office. Mid-level providers will include physician's assistants or PAs and nurse practitioners or NPs. Mid-level providers are also known as physician extenders because they extend the work of that physician. Physician's assistants are licensed to practice medicine with physician supervision. So a PA program takes approximately 26 and a half months to complete. And then your nurse practitioners will have a master's degree in nursing. Mid-level providers often are reimbursed at a lower rate than physicians. Although the scope of practice will vary by state, mid-level providers will require oversight by a physician. Each state will have regulations on the scope of practice that can be performed by each level of provider. Although some patients will pay in full for their own medical expenses, most patients will have some type of insurance coverage. As a coder, it is important to understand the individual payers, and they may have specific coding requirements. Insurance carriers are broken down into two groups. You have private and governmental. Private carriers can be referred to as commercial carriers, and they may also provide governmental plans, such as your Medicare Advantage plan, in addition to those private plans. Some commercial carriers can offer both group and individual plans. Group plans are often offered through your employers. Your individual plans are purchased directly from the insurance carrier. So some examples of commercial carriers are Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, and many others. Government insurers will include Medicare, Medicaid, and TRICARE. Medicare is administered by the Centers for Medicare and Medicaid Services, or CMS. Medicaid will be a combination of federal and state resources, and those are for low-income people. And then your TRICARE is for armed forces personnel and their family. Medicare is broken into several parts. Part A will cover inpatient hospital care, as well as provided in skilled nursing facilities, hospital care, and home health care. Part B covers medically necessary physician services, outpatient care, and other medical services that are not covered by Part A. Part C is also called Medicare Advantage. The coverage is managed by your private insurers, and they may include a combination of Part A, Part B, and sometimes Part D. And then Part D prescription coverage, those will be available to Medicare beneficiaries. Coders working in physicians' offices will mainly work with Part B Medicare or Part C Medicare Advantage. Documentation is the recording of pertinent facts and observations about an individual's health history, including past and present illnesses, tests, treatments, and outcomes. The medical record will chronologically document patient care to assist in continuity of care between your providers, facilitate claims, review, and payment, and it can even serve as a legal document. It is imperative that all services that are provided to a patient be supported and documented within the medical record. A coder is required to read and understand the documentation within a medical record in order to code accurately the services that are rendered. Different types of services are documented within the medical record, such as your evaluation and management services, operative reports, x-rays, labs, and so on. Evaluation and management services are often provided in a standard format such as SOAP. Not all E&M documentation will be documented in a clear SOAP format. However, each chart should contain the components of the visit. So your subjective is going to be the patient's statement about their health, including the symptoms. In this instance, the patient comes in for her annual diabetic foot check. She has no known allergies, and she has been diabetic since 2012. She takes 81 milligrams of aspirin daily, and she does have diabetic shoes and denied any cigarette or tobacco use. The objective is where the provider assesses and documents the patient illness using observation, palpitation, auscultation, and percussion. So here on exam, she has elongated, thickened toenails 1 through 5 bilaterally. Finding is consistent with fungal toenails, and the provider discussed diabetic foot care do's and don'ts. The assessment section is the evaluation and conclusion that is made by the provider. So here we have the assessment includes fungal toenails, diabetes, and toenails causing pain. And then lastly, the plan is going to be the course of action. So the provider reduced all the toenails manually and with an electric grinder. Your operative reports are used to document the detail of a procedure that is performed on a patient. Most operative reports will have a header and a body within the report. The header might include the date and time of the procedure, names of the surgeon, co-surgeon, or assistant surgeon, type of anesthesia and anesthesia's provider name, any pre-op and post-op diagnoses, the procedures that are performed, and there may be complications that are present. The body of the report might include the indication for surgery, the details of the procedure, and any findings that are a result of the procedure. Typically, around 20% of an operative report will contain words that are less important to you as a coder. So a coder is tasked with breaking down the information and applying the correct code. As you read through the note, you will want to highlight any terms that are unfamiliar to you. This will remind you to research the terms so that you have a better understanding of the procedure that is performed. In this example, it is helpful to understand the terms intra-articular and saucerized, and then your abbreviations ACL and SMC, and then the location of an anterior horn and posterior horn of the meniscus. When you have a pre-op and a post-op diagnoses within the report, you should use the post-op diagnosis to extract your codes. Make sure to also read the body of the operative report as well to ensure that there are not any additional diagnoses that are found. If a pathology report is available, you should use the findings from that pathology report for the diagnosis. In this scenario, we have a pre-op and post-op diagnoses, and they are the same, but we would still just extract the data from the post-op diagnosis for right knee lateral discoid meniscus. When you are reviewing the operative report for the procedures, you want to start with the procedures that are listed within the header. You want to read the body of the report to ensure that the procedure is listed correctly. And you will also want to make sure that you identify the procedures within the body of the report that may not be listed within the header. So here we have the procedure performed as a right knee arthroscopy, lateral meniscus ossuration, and then a lateral meniscal repair. While reviewing, you want to look for those key words within the operative report, such as an anatomic structure that is involved, surgical approach, procedure method, procedure type, maybe a size or a number, and then even the surgical instruments that are being used during the procedure. So here we have a 3-portal knee scope was performed. So that's going to be indicative of an arthroscopy. Our location is going to be the lateral meniscus, and they used it with a rim of 8 millimeters to do a saucerization. The anterior horn was noted to be detached. They roughened up the area and placed the number 2 fiber wires using the spectrum technique. They were tied down with SMC knots, and she was also noted to have a horizontal cleavage tear of the posterior horn, which they also roughened up with the shave and then rasp, and a single fast fix was placed to close down the space. Again, you want to be sure that you read the entire operative report. So sometimes there will be information in the body of the report that is not found within the header. You want to pay special attention to documentation of a procedure that was abandoned, if it was complicated, if it was extensive, or if there was extra time that was involved. So within the documentation, depending on what is noted, you may have a modifier that is necessary. As we know, just because there is a fee for a code does not mean that the provider will be reimbursed. So in order for a carrier to reimburse for a service, it does have to be medically necessary. According to CMS, the definition of medical necessity is services or supplies that are proper and needed for the diagnosis or treatment of the medical condition. They are proper for the diagnosis, direct care, and treatment of the medical condition. They meet the standards of good medical practice within the local area, and procedures that are not mainly for the convenience of you or your provider. Now, you have regulations that govern medical necessity that are found in the Social Security Act. CMS develops policies based on items or services that are covered by the Act. CMS is not allowed to cover any items or services unless it has been put through the legal requirements. The statutory and policy framework within the national coverage decisions may be found within Title 18 of the Social Security Act and in Medicare regulations and rulings. The National Coverage Determinations, or NCDs, will describe whether specific medical items, services, treatments, procedures, or technologies can be paid for under Medicare. Medicare administrative contractors are responsible for interpreting national policies into regional policies. These are called LCDs, or local coverage determinations. These LCDs only have jurisdiction within their regional area, and the MACs may also define what codes are needed for coverage in a related billing and coding article. This is a sample of an LCD for routine foot care. This snapshot will show the LCD ID, which is L35138, the title, which is routine foot care, effective dates, and the end dates. This section is the coverage guidance, which will indicate when a service is considered medically necessary. This is only a portion of the indications, as the section is fairly large. This section will cover the limitations, such as when they are not covered. The general information section will cover the documentation guidelines that are necessary. Again, this is only a portion of the documentation guidelines section, as it is a fairly large section. Here we have associated documents section, and this will show any previous publications of the LCD. It will also show any coding articles that apply to this LCD. Coding articles will include CPT, ICD-10-CM, and HCPCS codes that are applicable, as well as any modifiers that are associated with the coverage. Now, this is an example of the article, and it is formatted similarly to an LCD in that they show the ID, the title, the effective, revision, and ending dates. The article guidance section will show the coverage guidelines, which can include CPT codes and or any modifier usage. The coding information section will show your CPT codes that will apply to this article and the LCD. Also in the coding information section, you will find ICD-10-CM codes that support medical necessity. If you are providing this service and the patient's diagnosis does not support the medical necessity requirements per the particular coding policy, that your practice would be responsible for obtaining an advance beneficiary notice, or an ABM. The practices should check policies quarterly in order to maintain compliance. Other carriers may or may not recognize ABN forms, and careful research is needed to determine use outside of Medicare. In some instances, health plan contracts may have a hold harmless clause that is found within the language that prohibits the billing to the patient for anything other than copays or deductibles. Now, your provider should use that ABN when a Medicare beneficiary requests or agrees to receive a procedure or service that Medicare may not cover. The ABN is a standardized form that explains to the patient why Medicare may deny the particular service or procedure. And additionally, an ABN protects the provider's financial interest by creating a paper trail that CMS will require before a provider can bill the patient for payment if Medicare denies that coverage for the stated procedure or service. The providers are responsible for obtaining an ABN prior to providing the service or item to the beneficiary. The form must be filled out in its entirety, as well as the cost to the patient and the reason why Medicare may deny the service. Only the approved form CMS R 131 is valid, and the form may not be altered in any way other than putting the practice information in the header area. As we discussed in the beginning, the healthcare industry is heavily regulated. HIPAA is the Health Insurance Portability and Accountability Act of 1996. HIPAA is a 5-part act, but the part that is most concerning to the position of a coder is Title II, which is also known as Administration Simplification. Administration simplification will address national standards for electronic transactions and code sets. It establishes unique identifiers for providers, health plans, and employers in order to be used nationally. And then it provides federal protection from the privacy of personal health information. The code sets that are mandated by HIPAA will include HCPCS, CPT, CDT, ICD-10-CM, and NDCs. It is important to remember that although HIPAA mandates the use of the specified code sets, it does not mandate the use of its conventions or its guidelines, with the exception of ICD-10-CM. The Health Information Technology for Economic and Clinical Health, or HITECH Act, that was enacted as a part of the American Recovery and Reinvestment Act of 2009, and it was signed into law in February of 2009 to promote the adoption and meaningful use of health information technology. Subtitle D of the HITECH Act will address the privacy and security concerns that are associated with the electronic transmission of health information, in part through several provisions that strengthen the civil and criminal enforcement of HIPAA rules. HITECH has strengthened HIPAA rules, and it establishes more responsibility for business associates complying with HIPAA. It also allows patients to request an audit trail of health information that is made through any electronic record. On the website for the Office of the Civil Rights, you can find case examples of violations of the HIPAA Privacy Act. This example from the website shows where a nurse practitioner accessed her ex-husband's medical records, and she was ultimately reported to the licensing authority. More case examples of violations can be found on the OCR website. The OIG acknowledges that patient care is and should be the first priority of a physician practice. However, a practice's focus on patient care can be enhanced by the adoption of a voluntary compliance program. A voluntary compliance program provides physician practices with many benefits, including faster and more accurate payment of claims, diminished chances of payer audits, and sending a signal to employees that compliance is a priority. Although a compliance plan is currently voluntary, the Patient Protection and Affordable Health Care Act of 2010 will require physicians who treat Medicare and Medicaid beneficiaries to establish a compliance plan. and the effective date will be set by future legislation. MIPS is a combination of three former quality initiative programs: the Physician Quality Reporting System, or PQRS, the Medicare Electronic Health Record Incentive Program, or the Meaningful Use, and then your Value-Based Payment Modifier, VM. And it has put it all into one new component, which provides a single quality reporting system with a single payment adjustment factor based on individual and group performance in Medicare Part B. MIPS is a payment neutral program, meaning successful reporters will earn positive payment adjustments that are funded by an unsuccessful reporter who receives negative payment adjustments. Clinicians that are eligible for MIPS programs are your physicians, your nurse practitioners, physician's assistants, clinical nurse specialists, nurse anesthetists, clinical psychologists, physical therapist, occupational therapist, speech language pathologist, qualified audiologist, and then registered dietitians or nutritionists. MIPS is based on 4 categories: quality, promoting interoperability, improvement activities, and cost. Quality is used to assess the value of care to ensure patients get the right care at the right time. Promoting interoperability is used to ensure the secure exchange of health information and the use of certified electronic health record technology, or CEHRT, for the coordination of care. The 4 objective measures are e-prescribing, health information exchange, provider to patient exchange, and public health and clinical data exchange. The goal of the improvement activities performance category is to promote practice access, population management, care coordination, beneficiary engagement, patient safety and practice assessment, participation in an APM, health equity, emergency preparedness and response, and integrated behavioral and mental health. There are approximately 90 weighted measures within this quality measure set. And then lastly, the goal of the cost performance category is to create efficiencies in Medicare spending. Cost measures will assess a patient's total cost of care during the year or during a hospital stay and or during certain episodes of care. Advanced APMs will include bundled payments for care improvement, comprehensive end-stage renal disease care, and comprehensive primary care plus. MIPS eligible clinicians who are on the participation list of one or more advanced APMs during a determination period, also known as a snapshot, are not required to report MIPS data. They may also qualify for a 5% incentive if they achieve threshold levels of payments or patients through an advanced APM or the all-payer and other payer option. The snapshot dates will be March 31st, June 30th, and August 31st. The OIG Compliance Program Guidance, or CPG, for individual and small group physician practices was published in the Federal Register on October 5th, 2000. In October of 2023, the OIG published the OIG's General Compliance Guidance, or GCPG, which applies to all individuals and entities that are involved in the healthcare industry. The GCPG is designed to modernize the OIG's guidance. However, the existing CPGs and supplemental CPGs will remain available for use as ongoing resources while the OIG develops and publishes new guidance documents. Additional industry segment specific CPGs are forthcoming. The 7 key components to an effective compliance plan will include the following: written policies and procedures, implementing compliance and practice standards through the development of written standards and procedures. After the internal audit identifies the practice risks area, the next step is to develop a method for dealing with those risk areas through the practices, standards, and procedures. Written standards and procedures are a central component of any compliance program. These standards and procedures will help to reduce the prospect of erroneous claims and fraudulent activity by identifying those risk areas for the practice and establishing tighter internal controls to counter those risks, while also helping to identify any aberrant billing practices. Next, we have the compliance, leadership, and oversight. Designing a compliance officer or contact to monitor compliance efforts and enforce practice standards. Ideally, one member of the staff needs to accept the responsibility of developing a corrective action plan if necessary and to oversee adherence to that program. This person can either oversee all compliance activities for the practice or play a limited role merely to resolve the current issue. For training and education, conducting appropriate training and education on practice standards and procedures. Education is more important to any compliance program. Ideally, education and programs are tailored to the provider's practice's needs, specialty, and size, including both compliance and training. Next, we have effective lines of communication with a compliance officer and disclosure program. So, developing open lines of communication, such as 1, discussions at staff meetings regarding how to avoid erroneous or fraudulent content, and 2, community bulletin boards to keep practice employees updated regarding compliance activities. The OIG believes that all practice employees, when seeking answers to questions or reporting potential instances of erroneous or fraudulent conduct, should know whom to turn to for assistance in these matters and should be able to do so without fear of retribution. Next, we have enforcing standards. For the consequences and incentives, enforcing a disciplinary standard through well-publicized guidelines. The OIG recommends that a provider practices enforcement and disciplinary mechanisms ensure that violations of the practice's compliance policies will result in consistent and appropriate sanctions, including the possibility of termination against the offending individual. Risk assessment, auditing, and monitoring. This will be conducting internal monitoring and auditing through the performance of periodic audits. The ongoing evaluation includes not only whether the provider practices, standards, and procedures are current and accurate, but also whether the compliance program is working. For example, whether individuals are properly carrying out their responsibilities and claims are being submitted appropriately. Lastly, we have responding to detected offenses and developing corrective action initiatives. Responding to appropriately to those detected violations through the investigation of allegations and the disclosure of incidents to appropriate government entities. It is important that the compliance contact or other practice employee will look into possible violations, and if so, they need to take decisive steps to correct that problem. As appropriate, such steps may involve a corrective action plan, the return of any overpayments, a report to the government, and then a referral to law enforcement authorities. Now, this is a highly condensed summary of the OIG's recommendations. Both the GPCG and the Compliance Program Guidance for Individual and Small Group Physician Practices are relevant today. For a complete explanation of the components of an ideal compliance plan, you will want to visit the OIG website at oig.hhs.gov. Another report that is published by the OIG is the OIG Work Plan. The OIG Work Plan is updated monthly on the OIG website. It outlines the OIG's priority for the fiscal year ahead. A medical coder should be aware of the OIG Work Plan to know where the OIG's focus is going to be in the coming year. This example identifies that they will be reviewing the claims of a provider who performed lower extremity peripheral vascular procedures in an office setting in order to determine whether the procedures complied with CMS requirements and met applicable treatment guidelines. The next example will demonstrate the OIG's focus on Medicare payments and then to physicians for hyaluronic acid injections in accordance with Medicare requirements. Thanks for listening to the Compliance and Regulatory Overview. Make sure to subscribe to our channel to be notified of any new videos as soon as they are released.